A very good morning to all the students. I think previously we done the first part of the pharmacology class. I think we are very much well on with it. So today we will discuss just 1 minute. I think we discussed about the rate of absorption, right? Rate of absorption is finished. The rate of absorption, the curves were discussed, right? So we will discuss about PGP today, and from there we will start all the topics. We'll discuss about PGP substrates. We'll discuss about pharmacokinetics, and we'll also discuss about some other important topics like volume of distribution. Then we will discuss about dialysis agents which cannot be done on the dialysis. Then we'll discuss about metabolism regarding pharmacokinetics, and we'll also discuss about the dose response curve, right? Then we'll also discuss about something like very important, therapeutic index. It's very important topic. 3-star, you'll get one MCQ for sure from therapeutic index. Then we'll also discuss about drug receptor interaction. This is the basics of pharmacology. It's the basis of pharmacology, right? Then we'll discuss something about receptors, types of receptors, examples, and all those things, right? It's about receptors, right? And we'll also discuss about trails, pharmacological trails. This is, you have a potential MCQ, that's for sure. Then we'll discuss about something called adverse reactions, right? Then we'll discuss about TDM, therapeutic drug dose monitoring. There's a more MCQ. Then whatnot, we'll discuss about some pharmacogenetic conditions. It's not important, but still you might get a MCQ in Inicet from this topic. Inicet topic it is, pharmacogenetic conditions. And we'll discuss about the PDCs, the pregnancy drug categories, PDCs, which are safe, which are not safe, what are the categories, different types of categories. And finally we will start the autonomic nervous system drugs, right? So we will discuss all these topics today itself, and we'll finish as fast as possible. Okay, right, let's start the topic. Today's topic, the PGP substrate. What is meant by PGP? It's plasma glyco. It's plasma, it's P glycoprotein, right? What is PGP? It's P glycoprotein, right? It's a glycogen bind with a protein substrate. So PGP, P-glycoprotein, right? So PGP, or also in other words, it can be defined as multi-drug resistance 1 pump, MDR1 pump, right? So this is about PGP. We'll discuss what a PGP is. PGP, the P-glycoprotein receptor, is present on the intestinal epithelial cells. What it does, it simply efflux, means pushes the drug outside of the cells. It simply helps in the excretion or something called pushing out the drugs to outside of the cell. That is called efflux of drug. Influx means it is carrying inward into the cell. Efflux means it is pushing outward to the outside of the cell. That is extracellular. That is outside of the cell, right? So it helps in efflux of the drug. Drug efflux is done by PGP. Now what happens is, if the drugs are efflux or sent outside of the cell, it leads to decrease in drug absorption. Now decreased drug absorption leads to what happened? Decreased bioavailability. So the availability of the drug to the tissues also gets decreased. So with all this concept, you can understand one thing. If something induces the PGP, that means if something increases the activity of PGP, obviously the drug efflux or the movement of the drug to outside of the cell also increases, thereby it leads to drug failure. So PGP inducers, the components which induce PGP obviously leads to drug efflux. The drug gets to outside of the cell, it moves to the outside of cell, so the absorption will not happen. If the drug absorption will not happen, obviously the bioavailability of the drug to the tissues also decreases. So obviously the drug will not work, the action of the drug will not be completed. So obviously when the drug efflux increases, the drug obviously fails. It leads to drug failure. So PGP inducers causes drug failure. If they inhibit the PGP, if a component inhibit the PGP, or they are called PGP inhibitors, if the PGP is inhibited, what happen? Drug influx occurs. Drug influx occurs means more amount of drug resides in the cellular component, more amount of drug gets absorbed. If more amount of drug gets absorbed, it leads to more amount of stagnation of the drug in the tissues, which causes drug toxicity. See, the concept is very simple. If something induces the PGP, it simply effluxes the drug, means sends the drug to outside, thereby causing to decreasing of the absorption of the drug. So it decreases the availability of the drug to the tissues, thereby leading to drug failure. But if something inhibits the PGP, the drug remains in the cell, or drug is absorbed by the intestinal cells and gets remained inside for a long period of time, and the action of the drug also increases beyond the normal time, and it may lead to drug toxicity. So PGP inducers causes drug failure, PGP inhibitors causes drug toxicity, right? Now you will learn about PGP inducers, the components which induce PGP, the components which inhibit PGP. But what are those inducers and what are those inhibitors? We will learn today, right? Now substrates. Right? Just 1 minute. Just 1 minute. Please be on the line. Now, what are the PGP inducers? Example, rifampicin, quinidine. Now, you be heard about a statement called rifampicin leads to what? OCP failure. You heard about this? Rifampicin leads to OCP failure. Why? Can anyone tell? Because OCPs are, I will tell you in the next part. Remember. Why no one is answering? So just remember PGP substrates, not PGP inducers. No. These two are PGP inducers. These are PGP inducers. Now what are PGP inhibitors? What are the examples for PGP inhibitors? You can remember it with a mnemonic vaccine. V for verapamil, A for amiodarone. What is amiodarone? Can anyone tell? We'll discuss in the next class. Amiodarone, very important drug. It has potential side effects, it has potential uses, and its mechanism is also very important. It's an MCQ topic you will be getting mostly in INICT rather than Neet PG. So amiodarone is very important drug. Trust me, you read as many number of times as you can amiodarone, right? Now cyclosporin. What is cyclosporin? In which chapter you will be getting? Chemotherapy or anti-cancers? Cyclosporin is also a potential MCQ. Itraconazole, a very important antifungal whose mechanism of action should be read multiple times. Itraconazole. The side effects are also very important. Next, nifedipine. A good calcium channel blocker. Its potential side effects are MCQ questions. And finally, erythromycin or clarithromycin. What are erythromycin and clarithromycin? To which class they belong to? Macrolides. They belong to macrolides, right? Now, so what happens? What is meant by this? These are the PGP inhibitors which increases the drug toxicity if they are given with some particular drugs. For example, those drugs are called PGP substrates. What are those PGP substrates? Digoxin. Next one, protease inhibitors. Where will we use protease inhibitors? Mostly human immunodeficiency virus syndromes, right? HIV. Protease inhibitors is a potential MCQ topic. Please revise as many times as you can. Loperamide and bile acids. So these are the examples of potential substrates. So I will explain you shortly. If these inducers were given with these substrates, they will increase the drug toxicity of these substrates. If the inhibitors were given with these substrates, they will inducers will cause the drug failure, that is rifampicin and quinidine. PGP inducers will cause the drug failure. Means which drugs? These substrates, their mechanism of their action, not mechanism of action, their action, their duration of action can be altered, may be altered due to this inducers or inhibitors. For example, if these inducers were given with these substrates to a patient, obviously these inducers will cause drug failure of these substrates. If the inhibitors, verapamil, amiodarone, cyclosporin, itraconazole, nifedipine, erythromycin or clarithromycin, these are the PGP inhibitors. If these inhibitors were given with these substrates, obviously these inhibitors will cause drug toxicity of these substrates. For example, if any of these PGP inhibitor drugs, for example any of these 5 drugs, if given with digoxin, obviously they cause digoxin toxicity. Why? Because the PGP receptor, the PGP P glycoprotein is inhibited. If it is inhibited, the drug remains in the tissues or the cells intracellular for a long time. So obviously duration of action has also increased. That may leads to drug toxicity. Okay, so you got it right. That is the concept of PGP. Are we clear? If it's okay, we'll go to the next, right? Now pharmacokinetics, the next step is distribution. Guys, this is very important topic. You may get a potential MCQ or a problem, right? You may get a mathematical question from this, right? Because it has one or two formulas, you just remember, right? Volume of distribution. If a drug is given to a patient, what happens is the drug goes into the body of patient, it goes into the blood column. This is the vascular component. It goes into the vascular component. From there it goes into the body tissues. Now the capacity of the drug to get transported from the blood column or the vascular component to the body tissues, the amount or the quantity of the drug component that is being distributed from vascular component to the blood to the body tissues, that volume is defined as the volume of distribution. For example, if a drug X is said to have high volume of distribution, it's represented by VD. High volume of distribution, that means this drug X moves from vascular component to blood tissue, body tissues very much. It gets easily distributed in a large quantity, right? That means it has high volume of distribution, right? That means it has high volume of distribution. That means it moves in a large, it can be easily distributed from blood component or the vascular component to the body tissues. That means it has high volume of distribution. Now you have one more term called apparent volume of distribution. Right now I will not say what is meant by this, but in the next topics with an example I can make this concept very clear. But why? Because if I tell you right now, you may not understand. What most of the doctors do is they simply mug up this topic, but finally you will be getting 2 MCQs from this topic in the INSCT. Ultimately you will make a mistake. That's why most of the people, even though they prepare for INSCT, but still they don't get seats, or they don't get good ranks. Of course they will get 2000, 3000, but they don't get ranks below 1000. Why? Because they make some silly mistakes. Even most of the doctors, they find funny, most of the professors find funny why these doctors make silly mistakes in very simple topics, because they make it complicated, right? I don't want to make it complicated for you. I will make it as simple as I can, right? So just remember this apparent volume of distribution, this topic, right? I will explain you later. Now, what are the factors affecting the volume of distribution? What are the factors affecting the volume of distribution? First factor is, guys, remember this very much, it's lipid solubility. It's lipid solubility, or it can be also be determined with term pK. What is meant by pK? pH at which 50% of the drug, it also depends on this term, 50% of the drug is ionized, right? pK. So for example, if the drug is more lipid soluble, it can easily enter the cells more easily. Cells means it can easily enter the body tissues. It can easily be transported into the body tissues very easily. That means it has high volume of distribution. So high lipid solubility determines high volume of distribution. Now the second one is, it also depends on adipose tissue. In which people you have or you observe high amount of adipose tissue? Obese people, right? Now what is the other factor? Can anyone tell what is the third factor? Plasma protein binding. plasma protein binding, right? In plasma protein binding, I want to tell two things. In plasma protein binding, I want to tell two things. Albumin, albumin is a plasma protein, right? It's an example of plasma protein. Albumin binds to acidic drugs. And alpha 1 glycoprotein, alpha 1 acid glycoprotein binds to basic drugs. Guys, previously we discussed about this topic, no? So remember, plasma protein binding, the volume of distribution also depends on the plasma protein binding. In plasma protein binding, remember two things: albumin, which is one of the plasma protein which binds mostly to acidic drugs, and alpha 1 acid glycoprotein, right? It's alpha 1 acid glycoprotein, which binds mostly to basic drugs. Acidic drugs get more absorbed in acidic medium, that is in stomach, and basic drugs absorb mostly in alkali medium. Alkali medium present where? Small intestine. In which part? Duodenum. Why? Presence of bile. Okay, so I think you understand up to here. Now we'll discuss something. If someone asks you, they will be given the dose of the drug, they will be given the initial plasma concentration, D for dose of the drug, and C naught is the initial plasma concentration of the drug. Now they ask you to calculate apparent volume of distribution. The formula is simple: dose divides the initial plasma concentration. This gives the apparent volume of the drug, right? This gives the apparent volume distribution of the drug. Now if someone asks you what is the loading dose of the drug, then it is apparent volume of the distribution, times the target plasma concentration. Apparent volume distribution into target plasma concentration. That means, what is this target plasma concentration? So what concentration of the drug should be obtained in the blood? What loading dose should be given to the patient in order to obtain a particular target plasma concentration? For example, you want to give or you want to obtain a target plasma concentration of 20 micrograms per liter of the body fluid. So what is the loading dose of the drug you should give, right? So that is the target plasma concentration. For calculating the loading dose, you can simply multiply apparent volume of distribution into target plasma concentration, that is CT. If the examiner asks you apparent volume of distribution, you simply divide dose of the drug by initial plasma concentration, that is CO. Okay, now with this equation, that is the loading dose equation, you can simply get a matter of fact like loading dose simply depends on apparent volume of distribution. It simply depends completely on apparent volume of distribution. For example, if the apparent volume of distribution of the drug is very high, obviously the loading dose also should be very high, right? That's why some of the drugs, their loading dose is very much high. You should give those loading dose something like 1 gram, 2 gram, 4 gram, like that. See, 4 gram may look like a little dose, but still in cases of drug pharmacology, 4 grams is too high, it's too much. So loading dose of 4 grams is too much. Why you should give this much of loading dose? Because the drug has high apparent volume of distribution. That's why you should give more amount of loading dose. So loading dose, it directly depends on the apparent volume of distribution. These things most of the teachers, they don't teach you even in the digital session or live session. Why? They look like a simple thing, but still they should teach it to the student. Why? Because student should understand why paracetamol should be given only 650 mg, why lithium should be given only something like 0.2 microgram or 0.4 microgram, why erythromycin should be given 500 milligram and should not exceed 2 grams, why paracetamol should not exceed more than 10 grams per day. See, this all is depends on these factors, their volume of distribution, their apparent volume of distribution. There's also define their toxicity, the toxicity of the drug, right? So just remember this. Now we finish the loading dose and apparent volume of distribution. Now we will come to some other thing called dialysis. Now we will discuss about the volume of distribution. If the drug has high volume of distribution, that implies the drug can easily go into the body tissues. The drug can easily get on or transported into the body tissues. Now if the drug can easily get on into the body tissues from the vascular component, is it possible, for example, some drug toxicity has occurred, now it has high volume of distribution, now is it possible that it can simply be removed out, it can be taken out from the body? No, it is hell no. Why? Because the drug has high volume of distribution, means the drug can easily be transported from the vascular component to the body tissues easily. So within a fraction of some seconds or minutes, it gets easily be absorbed into the body tissues. Now how can you do the dialysis and separate the drug from the body, or take the drug completely outside of the body? You can't do it. So it's highly impossible. So what I want to explain is, there are some drugs. See, for example, if some drug toxicity has occurred, right? Right? What you will do? Obviously, the drug should go into the blood. It should be in the blood or vascular component. So, if you simply take to dialysis, what happened? The blood gets filtered, and you can expel the drug outside, and you get good blood or something called filtered blood, which don't have drug. Now if the so-called drug has high volume of distribution, the drug will not be in the blood or the blood column or the vascular component anymore. It will be transported into the body tissues rapidly as soon as the patient ingests the toxic drug or the drug itself. As soon as the patient ingests the drug, it gets readily be absorbed into the body tissues. So what you will do with the dialysis? Even though if you do the dialysis is only done for the purification of the blood. But if the drug has already been entered into the body tissues, what you will do by purifying the blood? There will be nothing. It's useless to do the dialysis. So what are the drug toxicities in which condition or in which drug toxicities dialysis cannot be done? In which drug toxicities dialysis cannot be done? Right? In which drug toxicity dialysis cannot be done? So those are the condition in which dialysis is ineffective. Dialysis is ineffective against drugs with high volume of distribution. Remember this, guys. This is very important question. You will not get a direct MCQ. You will get an indirect MCQ. A 28-year-old male came with a complaint of vomitings, diarrhea since the past 2 hours after an ingestion of an unknown drug, right? So after a few minutes of inquiry, the drug came to be known as diazepam, because the patient relatives has bought a tablet strip and it was noted as diazepam. And can the dialysis be done in this drug poisoning? No. In benzodiazepine poisoning, you can't do the dialysis. Even though you do the dialysis, it is useless, because the drug has high volume of distribution. It has already entered the body tissues. It is already been absorbed into the body tissues. So even though if you purify the blood through dialysis, there is no use. The drug is already in the tissues itself. So you can't do anything with the dialysis. So dialysis is ineffective against the drugs with high volume of distribution. So remember this point, very very important. You will get a potential MCQ on this concept itself, right? So in which drug poisonings dialysis is inefficient? First one is benzodiazepines. Now if the dialysis cannot be done, then there should be some antidote. If the dialysis cannot be done, at least we should give some antidote, some chemical component which will neutralize this poisoning. So benzodiazepines, the antidote is flumazenil. Very important MCQ, guys. It's a direct MCQ. No more hiding. It's a direct MCQ. You take beta blockers, right? Which is the most potent cardioselective beta blocker? Nebivolol. Very important MCQ. Remember, this is a direct MCQ. Very important. Beta blocker. Now, what is the antidote for beta blocker poisoning? Glucagon. Right? Now, amphetamine poisoning. What is the antidote? It's ammonium chloride. Guys, remember this. These are very important poisonings, a potential MCQ. Digoxin. What is the antidote for digoxin poisoning? Digibind. Guys, actually this antidote or drug toxicity, this direct combination is not the MCQ. You will be given a MCQ like 24-year female came with a complaint of so and so, and the patient's relative history has been given like the patient has ingested some tablets which has led to these symptoms, and the tablets were denoted with a name called digoxin so and so power or so and so dose. So what is your treatment of choice? It's Digibind. So you will get all the indirect things in the question, but the topic or the concept is pure direct. The only thing is you remember these points. Digoxin. Opioids. What is the antidote? It's naloxone. Guys, this is very much important. Some of the doctors are saying that naltrexone. No, see, opioids is a short emergency condition, so you should give the IV emergency antidote drugs as soon or as fast as possible. Now the IV drug of choice that will be used as antidote for opioids is naloxone IV. Is an IV drug. Remember, it's a IV drug, right? It has been proved that this drug is the IV agent which is drug of choice used as an antidote for opioids, right? It has a loading dose and it also prevents the relapse. Remember this point, very much important. Not naltrexone, it's naloxone. Naloxone is the antidote for opioid poisoning. And what is the another poisoning? It's organophosphates. Now this is one more confusing thing to so many doctors. Why doctors get confused, I don't know. Organophosphates, sir, is it atropine or pralidoxim? It's atropine, man. Atropine. What you will do with pralidoxim? Pralidoxim is it's not the drug of choice. Atropine is the drug of choice for organophosphates. But if you ask me what is the direct drug, then it is pralidoxim. It's a straightforward drug, but it's not the drug of choice. Drug of choice is atropine. Remember very thing. Atropine 4 mg, 8 mg. Put it in the comment section. Atropine is given in organophosphorus poisoning. Right? Now, what is one more thing? One more example is there. That is CCB, calcium channel blocker. And antidote is, what is the antidote for calcium channel blocker poisoning? Calcium gluconate. Calcium gluconate is the antidote for calcium channel blocker poisoning, CCB. I think you are clear with this. We will go to the next topic. Right? Next topic is pharmacokinetics. What is meant by kinetics? Kinetics means what the body does to the drug. Pharmacodynamics means what the drug does to the body. You should revise all those things again and again, because we are human beings. We easily get confused, right? Okay. Now metabolism. When you come to metabolism, the drug metabolisms occur in two phases, phase 1, phase 2. So I will make it simple. I don't want to make it even more complicated. You just remember it's phase 1 and phase 2. Now what happens in phase 1 is drug inactivation. The body simply inactivates the drug, simply make the drugs inactive. And there is one exception for this, except prodrug. Why? Because in case of prodrug, it gets converted to active drug rather than inactive drug. Can you tell me one example for prodrug? Can anyone? Enalapril, levodopa is a prodrug, and as soon as we give the levodopa, it crosses the blood-brain barrier and it converts into dopamine, which is a active drug. Okay, so these are some examples, right? What happens in phase 1 is it inactivates the drug, or the drug gets inactivated. But if the given drug is a prodrug, then the prodrug gets activated rather than inactivation. Okay, what is the most common reaction in phase 1? The most common reaction is oxidation. Guys, this is a direct MCQ, no doubt in this. Oxidation, most common reaction in phase 1 metabolism of the drug is oxidation. What are the enzymes? Can anyone tell me? Cytochrome P450. Okay, here cytochrome is pigment. Okay, next most common enzyme is cytochrome P3A4. Now 3 is, what is 3 meant by? Family. A is meant by subfamily. And just 1 minute. A is subfamily, and this 4 is, what is this 4? Gene locus. I think examiners won't ask such PT things, but still PT examiners will be there. They might ask you PT questions, right? So simply remember this. What I am asking, 3 is family. 3 indicates family, A indicates subfamily, and this 4 indicates gene locus. Okay. Now, what happens in phase 2 reaction? It makes the drug more water soluble. Means, in other words, hydrophilic, water loving, hydrophilic. What is the most common reaction in case of phase 2? It's glucuronidation. Wait. Most common reaction is it's glucuronidation. Okay, it's glucuronidation. Yeah, okay. See, I just want to check whether it's in the page itself or not. If you want to write me in the below, I'll just write there. Okay. Now, most common reaction is glucuronidation. Now, what is the most common enzyme? It's glucuronyl transferase. See, it's in the name itself. Glucuronyl transferase. Now, I think we heard this glucuronyl transferase somewhere. The deficiency of glucuronyl transferase cause which disease? Crigler-Najjar syndrome. Crigler-Najjar syndrome. Guys, this is an important MCQ, but it's not the deficiency of so-called enzyme that will be given in the exam, but the symptoms of the Crigler-Najjar syndrome will be asked. Okay. Now, I will ask you one more thing. Just please be on the line.